Well, hello everyone, and welcome to RxSight Ed, an educational session provided to you by RxSight and the Light Adjustable Lens. My name is Matt Jensen, and I'm going to be your moderator for today's session. And I'm joined today by Dr. Kaufman. Hello, Dr. Kaufman. How are you?
Good. How are you?
I'm great, and I'm excited about these sessions. We've talked to a lot of doctors, and we'll talk to a bunch more about how they're implementing this technology at the point of care in their practice. And so we're eager to hear what you have to share. But I want to thank RxSight for putting together sessions like this that can help doctors learn from one another how to implement this exciting technology. Now, Dr. Kaufman, I want to just start off by asking you to give us a little bit of background about you, where your practice is, a little bit about maybe your patient demographics.
Yeah, sure. So I'm Matt Kaufman. I work in a very large practice in Portland, Oregon called EyeHealth Northwest. We have about 40 MDs. We have 18 offices. We cover sort of all geographic areas of the city of Portland. We kind of split ourselves up geographically. We call ourselves silos. And so I'm in the sort of east side, northeast section of the city. And we have a pretty interesting patient demographic. We have the highest patient volume, but we also have the lowest socioeconomic status patients in the city, just based on where we're geographically located. So, we see a lot of advanced pathology because of that, sort of high surgical volume, generally a lower premium lens volume, as you might imagine, with that patient population. But, pretty rewarding patient population, and it's a fun day at work.
Yeah, and give me a sense, if you don't mind, of what your adoption rate tends to be at that particular site, as maybe opposed to the other silos or sites, as you call them.
Yeah, so, my personal adoption rate for like any premium IOL is just under 20%. And I think we're probably in my group somewhere in that 15 to 20% range on any given year. Whereas some of our groups that are on the west side of Portland, which is a very different demographic, they're up closer. We have docs that are over 30% premium IOL conversion. So definitely a different market there.
Yeah. And, I'd like to pull on that thread a little bit, because as you talk about different socioeconomic regions within your city, your demographic, a lot of people find that technologies like the light adjustable lens can affect, your overall adoption rate. Have you seen any increase or decrease in your premium adoption after adding the light adjustable lens?
Yes, because it gave me an option to offer a premium IOL for patients that I might not have recommended a premium IOL for in the past. And so there are definitely a subset of patients that now I can say, I don't exactly know what toric lens to put in, but let's do a light adjustable lens, and we can correct your astigmatism based on your refraction after surgery. And so, that would be an example where it might increase my premium IOL adoption.
Well, that's really interesting the way that you said that, because it's not like a nice candidate for premium might not have adopted and now they are, but more that you're opening up a market of people who might not have been candidates in the first place.
Right. Yeah. Yeah.
So that's
for sure.
That's a curious observation. So, you're in a large practice. What made you and your group decide to adopt the light adjustable lens, including the LDD, right? Because it's a big decision.
Yeah, it was a big decision. It's interesting too, because we were the first silo in the EyeHealth Northwest practice to get light adjustable lens, which you wouldn't think based on our patient population and our lower premium conversion rates. But, we were actually, a couple of years ahead of our partners on the other side of town. We started looking at some of the data coming out, when light adjustable lens started coming on the market, we started talking to, our colleagues around the country, people we had trained with, people we know, who, had started adopting it. And when we started to hear about the results, that's what pushed us to it. I think what's interesting is that our group tends to be fairly conservative when it comes to premium IOLs. A lot of us have had a lot of frustrations with multifocal IOLs in the past, and some of the premium options. I know personally, one of my big frustrations with a lot of the premium IOLs is when you just don't hit the refractive target. So when you have a lens like a multifocal IOL, you know that you really have to nail that refractive outcome. And even with, our best biometry and best formulas, there's going to be times that don't. And that, really stressed me out a lot as a doctor. When I go in and I do what I know is a really good surgery, but then the patient doesn't get the outcome that they want, that just kills me, because I know I did a good job in that OR.
Yeah. Let's talk about that for a second, because there's a whole bunch of reasons why we might not land that plane right on the middle of the runway. Give us the reasons why that might be.
Yeah, I mean, if you look at some of the research, there was a really good paper published by Ron Mellas a few years ago, that looked at all the IOL formulas, and the Barrett formula, was the most accurate. But even with that formula, 20% of patients were outside of a half a diopter of the target refraction. And, we know that half a diopter matters too, especially when you're talking about, someone who wants that crisp refractive outcome. So, you may not do anything wrong, and you may still get that result. We have patients who are post-refractive. We have patients who have, cornea pathology that might not be detected on a biometer or on a topographer. We know that, different patients have different effective lens positions, and based on, whether it's an extra long eye or whether it's an extra short eye, that increases the risk of a refractive surprise. So there's all kinds of reasons why you might not hit your refractive endpoint.
Well, and I like the way you said that even in the best of patients, best of surgeons, a half a diopter variance for somebody who's investing, a lot in a pristine outcome can really be the difference between a happy patient and an unhappy patient. And then, so in the same vein, and I'm going to just have you spell it out for folks, but why is the light adjustable lens a nice answer to that challenging problem?
Well, it's funny. I did a talk about the light adjustable lens for a lot of our group, and I put a slide up with horseshoes and hand grenades. That was an old saying where I grew up, where you just had to get it close, like horseshoes and hand grenades.
Yeah.
And, to some degree, it's simplified, but at some degree, that's the ability that you have with light adjustable lens is, even when we miss by half a diopter or something, half a diopter, we're in the neighborhood. We're close. And the ability of the light adjustable lens to finish that refractive outcome and to just get it right on, that's what lets you sleep easy at night, knowing like I'm going to get it close, and then I'm going to get it perfect.
Well, and I like the way you said that too, because a half a diopter postoperatively, perhaps in other premium options, as patients heal, that might go farther, or not. And then you've got an option. There's still great options. Then you can either do a fine tune with a laser, or you can do a fine tune by putting spectacles back on.
Right.
But either way, you've got a big talk to have with the patients.
Oh yeah.
Right.
Oh yeah.
And so,
I mean, I've gone back to the operating room and done a lens exchange. I mean, that's the other option too when you're talking about some of those premium IOLs when you don't hit your refractive target.
So give me a sense of what your conversation is like with the prospective patient as you're talking about the light adjustable lens with cataract surgery. Okay, so I'm a cataract patient. You say, listen, there might be something for you. What do you say?
Yeah. What I tell them is that our measurements and our predictive algorithms and our fancy machines are really good, but they're not perfect. We're going to get you really close, but I can't guarantee that you will have your best possible glasses-free vision. The best I can give you is this light adjustable lens where whatever is left over at the end, when we do all our predictions and we try to get it as close as possible, we know there's going to be some left over. The light adjustable lens, we can walk down the hall and we can put the numbers in that we measure and we can say exactly where we want it to be. And we can reshape that lens inside your eye and we can get it as dead on as possible.
Now, I really want to come back to this conversation because how you talk to the patient, I think, is supremely interesting for the listeners of this conversation. I want to go back to your partner conversation, though, because you were the first silo or practice within your group or network that invested in the LDD. How did you make your case? Because there's a capital expense to it, and then
yeah. Well, again, it's one of those things where dealing with an unhappy premium IOL patient costs a lot of money because it takes a lot of time. If you're doing a post-op LASIK or PRK enhancement, if you're doing LRIs, or if you're going back to the OR to do a lens exchange, I mean, that costs money. That's real dollars. So, from that perspective, there's an economic case for it. And then in just the patient care, we like to pride ourselves on offering patients the best technology that's available. And, we know a lot of our patients can't afford it and might not choose it, but I want them to know that, we're going to give you absolutely the best possible options for your surgery. And so my partners are all on the same page about that. We want to provide the highest level of care. And now that this technology is available, I think we had to do that. We felt like we wanted to do that. We were excited about it, just from an MD perspective, being able to do that for our patients.
Now, there is a cost to the LDD. Did that concern you at all? Did you have to put pencil to paper and worry about that? Or how did you overcome that in your own mind?
Yeah, we're fortunate in that we're a big practice, so we would have a number of docs using it. We also, just from our group perspective, we had surgeons who were not using a lot of premium IOLs. They felt like the light adjustable lens was something that they could offer.
That's interesting.
Yeah. So, they might not offer that to some of their patients, but they felt more safe about the outcomes with the light adjustable lens, getting their refraction dead on, getting that vision to be as good as it can be. So, putting it all together, we weren't that concerned with it. And, it turned out to be economically, easy within a couple of months. We paid off the cost of the LDD pretty quick. That was actually surprising for us because we were so happy with the initial outcomes we were getting.
Well, there's a couple of things you've mentioned so far that I think are really noteworthy. One was the conversation about you just made about your partners. It might be their foray into premium because they can kind of walk the patient up to their desired satisfaction. Exactly. And I think that's really That's a really nice point that I haven't heard from anybody before. Very astute of your team to notice that. The second one is just how you thought about it beforehand, the overall cost, but then afterwards, it came more quickly than you thought. I think those both are noteworthy. Now you got your team involved as well, and they had to be trained and be kind of for it. Because nothing can make a day great or bring down the morale than your team. How did you get them involved?
Well, it was fun. Anytime you bring in sort of a groundbreaking technology, that's fun for everybody. And so, RxSight, their clinical trainers were with us quite a bit at the beginning, kind of walking everyone through it, from our surgical schedulers to our technicians in the lanes, to us, of course. So everybody was pretty on board, because this was something that we had never seen before. And, from my perspective, I remember being at a lecture at AAO in San Francisco in 2019, I guess it would have been, when David Chang was saying he was about to put in his first LALs. And, I had known the technology existed and that it was out there. And, one of my friends and I looked at each other like, come on, that can't really work. Like, that would be the holy grail, to be able to just adjust someone's refractive outcome after the surgery, after how they came out. And, of course, we had the pandemic and everything kind of was in turmoil. But once things got up and running and we saw, like, this is a real thing and it works. Like, that was exciting. So when we brought it into the office, everyone was really excited about it.
That's very, very well said. Now, with your team and also with the scheduling, talk to me about the choreography, because there are several visits. How have you navigated that and got it to a spot that's reliable for your team?
Yeah, it took a little trial and error, of course, at the beginning. And the interesting thing, I think, in our group is that it's not the same doctor to doctor. So even though, we're in the same office and the same group, different docs have decided to schedule, their treatments and their follow-ups, slightly different from each other. And we all kind of found what worked well for us. For me, we make 3 visits for adjustments afterwards, knowing that we're going to have an adjustment and 2 lock-ins. And, if we need more lock-ins, more appointments, then we'll certainly add those. Sometimes we're not, the patient and I, we're not sure where we're at just yet. And we let things sit for a little while. We live with it. And sometimes we're, 3 visits, we're done. Like, we're great. And so, you have to kind of find what works for your schedule. But that wasn't that difficult to do. And now, I think as our other silos of EyeHealth Northwest got on board, that became a lot easier, because they had our experience, first of all, and then RxSight, has had more experience as well, from the support side. And so they were sort of able to get things rolling much smoother, or much quicker, I should say, for our newer silos that have come on board.
Well, I really like that. And you talked about the choreography there of the team and the post-op visits. And then you said, sometimes we decide to live with it. I want you to kind of talk about that a little bit, because what you mean, I think, is you're talking about when they come in for maybe an adjustment and you decide to do nothing. And, and they go live with their vision for a little bit. How do you talk to the patient about that? And just talk me through the kind of the patient psychology.
Yeah, and this is a big thing in terms of that psychology. Sometimes I feel like I'm a psychologist and not an ophthalmologist at these visits, because, there's a tendency, I think, for some of these patients, and even, me at first, we want to tinker with it. We say, oh, there's adjustability here. Let's nip here and tuck there, and let's see what happens if we do this or that. And I've kind of, discretion is the better part of valor. And now that I have some more experience with this, I kind of know where patients need to be to end up. And sometimes they don't know that just yet. And so I need to kind of coach them on it and say, you're a lot closer to where you want to be than you think. They say, oh, maybe I want to change my right eye like this or my left eye like this. I say, well, before we do that, I'm pretty happy with your vision and I'm pretty happy with your numbers here. I want you to go live with it for a couple of weeks. Think about the times where you're actually not able to see what you want to see. Think about those times and then come back and we'll talk about it. And they come back and you say, you're right. Like if I didn't think about it and then I thought about it later, it was great. And yeah, let's lock in it. I'm done. And so that conversation happens all the time. But the tendency is, because I have this adjustability, I have to keep adjusting. And you don't.
You don't have to.
You don't have to.
What you said there that's really powerful that I think your colleagues can learn from is how you have the confidence to do nothing.
Totally.
And also that you are prescribing it's some doctors call it verbal anesthesia.
Yeah.
You're saying, listen, I want you to take your vision and go walk around for a couple of weeks and really notice when your distance is here, when it's here. Remind your brain to tell you when you're frustrated.
Right.
That's so powerful. And then the patient comes back and either wants to proceed with adjustments or yields to your thought that they're, okay where they are. It's brilliant.
Yeah.
It's brilliant.
Yeah. I had a patient a couple of years ago. She's like, I'm leaving on a trip to Europe. I'm going for 6 weeks. I want to be locked in. But I'm not sure. I said, go to Europe. Have fun. Go live your life, have your vacation, come back, and we'll see how you're doing, and we'll make our final decision on whether to adjust more or not. And she came back, 7-8 weeks later, and she was like, oh, my trip was great. I could see everything. It was amazing. It was like Europe was so beautiful, and lock me in, I'm done. And I knew that would happen, and it did.
Well, so that really leads me to another question, and because I know you run into colleagues all over the country and at the national meetings and otherwise. What do you say to people who say, who walk up to you and say, listen, I know you're using that lens, but it takes too long?
In this day and age, they expect LASIK-like results. And they won't settle for less. And so you have to have it. You have to be able to deliver for those patients. And so, is it going to take a little more time for those patients? It will. But it's going to take a real long time if you do a regular lens or a non-adjustable premium IOL and they don't get the result that they're looking for. And so, that's the way I look at it too, it's not always that much more time in the end of the day.
Yeah, I love this. And if you don't mind, and I'm just curious for others listening, if you can give me a range, don't give me the actual, but a range of where you have this priced in your program. Maybe give me a range of $400 or so.
It's just over $4,000 per eye.
Okay. Yeah. So and are your other premium offerings more or less or the same?
They're less. Our other premium offerings are less. Again, it's more time. It's also, in my opinion, the best lens we offer. It's the lens that I would put in my eye if I had to have surgery right now. And so, there's something to be said for that. So I feel like it's worth it for those patients and they feel like it's worth it too.
Well, isn't it a curious point that the fictitious doctor that I brought up who might say, doesn't this take too long? It takes a lot of time. And your response a couple of questions later is, yeah, but it's because of the time that I charge more.
Yeah.
Right. And so it's kind of like, yeah, I mean, that's also the benefit of the lens.
Right.
Is that it takes time.
Yeah.
So really great. So tell me about word of mouth in your program. Do patients, team members tell others about their experience?
Oh, for sure. I have a train of light adjustable lens patients that were referred from someone before them. Interestingly, like as I said, we on the east side of town got the light adjustable lens first. So a lot of my initial patients were coming from, other areas of the practice to us just to get the light adjustable lens. They had done their research on it and they wanted it, and our other groups weren't offering it yet, so they came and they tell their friends, and they're like, oh man, traffic was bad today. I wish they did it closer. So yeah, I wish they did it closer to you too. But for now, you're driving over to see me.
Yeah, that's great. I love those stories on how patients or team members get so excited that they share it with others. And I found that team members, this is something that they really understand and get behind. I want to ask one final question of you, Dr. Kaufman, and that's one of a colleague who asks you, why should I consider doing this? I'm kind of in consideration phase. Why should I take this seriously?
Yeah. I think the answer to that goes back to a lot of what I've said already. What we talked about tonight is you want to offer your patients, the best technology available. The light adjustable lens, in my opinion, is that. The optics are wonderful. You have this 3-piece silicone IOL. We know that is wonderful optics. You don't get the dysphotopsias associated with a lot of other premium IOLs. You're going to give them just an incredibly good quality of vision. A lot of people say to me, well, I hit my refractive targets all the time, to which I kind of raise an eyebrow. But, there's a difference between getting it close and getting it dead on. One of the things we saw originally was like how many just 2015 eyes we were getting with light adjustable lens, because when their refraction ends up planosphere, people can see really, really well. And until you kind of see that for yourself, you might not really believe it. So, what I would say is you want to offer your patients the best possible vision, the best possible outcomes. You want to have something available for them that is going to give them, what they're looking for in their outcomes, and the ability to kind of decide for themselves how they want their vision to be. And the only, product that can do that is the light adjustable lens.
Well, Dr. Kaufman, I want to thank you for joining us here on RxSight Ed, our educational series, brought to you by RxSight and the Light Adjustable Lens, where you've shared the pearls that other doctors can use at the point of care to help counsel patients, talk to them about their outcome, and really how to implement this amazing technology. So many great comments during our session today. There's a lot that I'm going to remember from it, but thanks for joining us and thanks for adding so much value to your colleagues.
Absolutely. My pleasure.